Hi, I'm Jens Chapman, and welcome to the Seattle Science Foundation. We thank you for your interest over the past years in our regular programming, and we will continue to look forward to a great new 2025 program series. As always, we pride ourselves in offering free and widely available high-quality content, and I'm, as a spine surgeon, always very intrigued in learning from this. In 2025, to support our mission, we'll have to charge for CNE credits, and this is doable through an all-access pass. This all-access pass will be differentiated for residents and fellows and for attending level or faculty surgeons. So please join us in the future. If you want to have CME credits, please do it through the all-access pass.
And we're live in 5,
4, 3, 2,
1.
Morning, Dr. Chapman, just in time. We'll have you introduced as usual. I wouldn't do it justice.
Oh, far from it. Good morning, everybody. It's Jens Chapman here. And today we have our June 4th edition of STED Talk, Spine Technology Education, and the D is multidimensional, discovery, discussions, and debate. And today's guest speaker is an awesome guy. It's Dr. Nick Morrisette. He's a neurodiagnostician, and I'll introduce him in greater detail later. But again, neuromonitoring is one of those things that we all have come to really depend upon and live by, and we have significant pressures nowadays, how much to use it and when to use it, because everybody's trying to cost cut. So as they're getting more and more sophisticated, we're also under pressures by administrators to maybe not use it as much. So it's a dichotomy. So we thought it's very timely to have him speak today. As always, we'll have a couple of pertinent cases that we thought we'd kind of run by his expertise first before we get his guest lecture. First is Dr. Nick Minnesali. He was already standing here wearing his Eagles colors again, and he's going to show something that vexes us a great deal, and we'll love to have your thoughts. And can you get that microphone in front of you, because I'll start going towards you right away. Nick.
Thank you. All right, good morning. So first case here, no relevant disclosures for myself. It's a 50-year-old female with chronic neck pain and left arm pain and paresthesias for years. Past medical history, she's a diabetic, but it's controlled at this point. BMI is 30, and then the usual hypertension, hyperlipidemia. Has a nightly glass of wine, does not smoke, quit 25 years ago as a former smoker. On her exam, she's intact motor and sensation with positive spurlings on the left that caused arm pain in the C5 to 6 dermatomes. She's failed years of non-operative treatment, including injections, PT, activity modification, as well as medications, but otherwise she's motor and sensory intact. So here we can see the lateral flexion and extension x-rays with loss of lordosis with multi-level subaxial spondylosis. Here's her MRI. It's T2 axial and sagittal images demonstrating significant left-sided foraminal stenosis, and then kind of unilateral central stenosis at C4-5 and 5-6. But you can see at the 4-5 level is quite stenotic throughout the foramen there. So, pretty straightforward case overall. Years of non-operative treatment for this patient, chronic neck pain, left arm pain, and she's failed all conservative treatment with pretty significant foraminal stenosis on the left at C4-5, which all correlate with her symptoms in that kind of C5 and C6 dermatome. So, there's multiple options for a patient like this. In some cases, you could do posterior foraminotomy, you could do anterior cervical discectomy infusion, or in a healthy patient like this with maintained motion, it's also a good idea sometimes to do anterior cervical disc replacement. So I can move forward with the results.
Yeah, the one thing here, so there's a 2-level disease process going on. Were electrodiagnostics obtained beforehand? Did the patient have diagnostic blocks of any sorts?
She had injections that would work for a little while. I don't recall if there's a specific block, like a transforaminal at 5.
And just out of curiosity, I'm not saying that should have been done. I don't know this patient. Was an EMG obtained pre-op?
It was not pre-op.
Okay. Were there clinical weaknesses? Sorry, I kind of missed the clinical.
No, from her exam, she was neurointact. It was very much neck pain and radicular pain.
Yeah, I didn't see anything here.
Yeah.
So, okay, so no myelopathy signs, no dermatomal things, reflexes are asymmetric, left side, okay, yeah.
Yeah, just triceps there.
Yeah. So go back to the imaging again. Is this then 2-level disease or is this 1-level disease?
2.
2-level disease, okay. And was a CT obtained?
A CT was not obtained.
Yeah. So the key question, I don't know this patient, but I know what will happen. I think 2-level disease in a younger patient, I would clearly nowadays prefer a disc replacement over a fusion. I would choose anterior over posterior because there's cord impingement, especially at that C4-5 segment, that seems to cross the midline and that's simply not amenable from a posterior approach. So 2-level disease would veer me away from a femonotomy. I think it's an underutilized procedure. For our audience, we've had the wonderful Tim Adamson, one of the big early proponents of this here several times, who's shown us how to do this. Totally underutilized procedure, but this would veer me towards a 2-level disc replacement. I'll just speak as a surgeon here.
Yeah.
What would you do?
I agree. I think inject a block pre-op to really distinguish her symptoms and decide against 1 versus 2 level, but I think 4-5 absolutely needs something anterior. I think I agree foraminotomy would not decompress the cord enough at this point, especially with her change in her reflexes. But
and I don't say, so let me interrupt you. I don't say perfunctorily. We as surgeons should also take active control of non-operative care. Like in a neck like this, I would not do neck range of motion. I would not do neck strengthening. These are things that are bound to irritate a neck like this. I would do axial, setting up traction twice a day. I would do shoulder rehab. I would certainly get a CT scan personally, and I would use at least a diagnostic block if I had any questions. I'd have a low threshold if there's a question of peripheral neuropathy versus radiculopathy to get electrodiagnostics, because there can be this frequent conundrum of carpal tunnel, whatever, cubital tunnel, or some other compressive neuropathy versus a radiculopathy. So let's move forward. But any thoughts on that?
No, I agree. I think in a patient like this, it may have been helpful because when I saw her post-op and discussed her symptoms, she said, what seemingly seemed like C5 and 6 distribution, but since no major changes otherwise in exam, it would be really nice to add that.
Great.
So drumroll, the patient did undergo a 2-level cervical disc arthroplasty with an unconstrained titanium-coated peak on ceramic implant. She did well. Post-op day 1, as this surgeon always obtains upright imaging, weight-bearing imaging. And she went home on post-op day 1 with 5 out of 5 strength in bilateral upper and lower extremities and was doing very well.
Was neuromonitoring used since we have?
Yes.
Good, okay. No changes?
I'll get there.
Okay.
So on post-op day 8, the patient had, post-op day 3, the patient called with significant worsening of left shoulder abduction weakness, and a Medrol dose pack was ordered, and then the earliest appointment that could be had was given to her. So she came in on post-op day 8. These are x-rays at that visit, which demonstrate no change, loosening, malpositioning of the implants compared to her initial films. But we do see that she has significant deltoid weakness and some biceps weakness on the left.
So, C5 palsy.
Yes.
So let me ask our guest here today, Dr. Morrisette and Nick. This is one of those vexing conditions that is really, I don't want to use foul language here, but it starts with an S and ends with a KS. This is, how often is this C5 palsy in anterior neck surgery?
5 to 10, well, the range is from 0 to 30%, 34%, but I think the pooled range is about 6%, which I'll talk about.
So this is an extremely frustrating situation, especially when it's in a post-primary onset like what we see here. I usually tell patients, I put it in my notes also 5 to 6%. It's usually a quote benign pathway. You'll talk about that, but and the variables of that, but you can do everything right, and there's nothing in the case that somehow is a worry, and then you get this. So let me start here with a general question. Artificial disc replacements, this has become, in the neck, this has become a kind of commodity surgery almost. Same day frequently, was it same day surgery?
She went home the next day.
Okay, but one night stay, short stay, or same day? And our hospitals don't want us to use neuromonitoring if they can help it. So what is your impression in terms of, is this common now to not do disc replacements with neuromonitoring?
As to the general prevalence of it, it's hard for me to comment on that across the board, what we see nationally. But what I will say is that I echo your sentiment entirely. This is very vexing through the lens of neuromonitoring as well. And it's not, unfortunately, it's not as uncommon as we would like it to be for patients to have these very delayed responses, or very delayed from our standpoint, symptomology following the surgery, particularly when everything in the intraoperative theater looks like it goes as planned. My recommendation for cases like this, particularly if they show up and they're already symptomatic and they're already displaying radiculopathy features, or particularly myelopathy, which is not relevant to this case necessarily, is to always do neuromonitoring within those cases. As to whether or not there are techniques that could be used that would detect if this patient was going to have a higher likelihood of developing a delayed postoperative deficit, it remains very vexing in our sphere as well. So as much as I wish I could shed light on that and say, do this, take this step, do this, and we will eliminate this from the pantheon of things that can happen, to the best of my knowledge, we just don't have anything to that degree yet. But again, the recommendation is always, from my standpoint, would be to monitor this case.
I mean, this is beautifully recorded here. What I have found, and this is totally empirical, is, and that's what worries me when we do a C4-5 decompression, there can be this brief burst of EMGs at C5. He's got his glasses on and he's recording. Dr. Scurry, and you're gonna be live on his Instagram channel later. Hello, Instagram. There's a brief burst of EMG and that's it. And later you'll see that there's some weakness, might not be bad like this, but 4 out of 5, something like that. So is that all we can sometimes see?
It can be, and I think that EMG has kind of taken a back seat in terms of its utility, or at least the way that it generally gets viewed. I think that motor evoked potentials kind of take the spotlight, but there's a tremendous amount of information to be gleaned from EMG, and there's a large pantheon of different responses that you can see within EMG. Now, again, I wish we could get to a place where we would have one-to-one predictive value for that. We just don't, but I would think that particularly in cases like this, EMG is an important modality and it should be paid attention to. Now, as to what type of interventional action you could take at that point, you see a large burst of neurotonic discharge, it's specific to C5, you probably should be thinking to yourself, okay, well, this patient may have a greater risk at this point in time as a result of that. But in terms of one-to-one prediction, it's very challenging. And these are the cases that are very vexing, not just from a neurosurgery standpoint, from a spine standpoint, but also from a neurophysiology standpoint.
We had this yesterday in a case. What does it mean when the electrophysiologist talks about a train? I'm looking at Jackie here. What's a train mean? Okay, the train keeps it coming. What does it mean?
Yeah, so essentially what we're talking about is what I just mentioned, where we have this pantheon of different responses in EMG. And so we can have a single response, which is just basically one CMAP response. You get a single firing at the neuromuscular junction, you get a single muscular response. That's one. A train is typically whenever we see continuous single discharges produced from the same nerve pathway, and that is almost always indicative of some degree of irritation to the nerve physically, and really should be, viewed as such.
So it's a far more significant thing.
Yeah.
All right, so let's carry this on. So
Yeah, so just stepping one step back, in the postoperative period for this patient, an EMG was obtained just kind of as a baseline and to see what maybe the prognosis could be if it showed anything. It didn't show too much. It did show the left C5 and possibly C6 radiculopathy. However, they commented that this was likely chronic and maybe would just not have shown up yet at this 23 days post-op. So I just wanted to show that. And then, as far as discussion about C5 palsy, we've covered a decent amount of it. This is just one study that was performed here at our institution as a systematic review that had 16 included studies. Again, the pooled prevalence of C5 palsy was about 6%. And again, as we said, this is a pretty vexing problem. There's really no consistent evidence, strong evidence that C5 palsy is associated with any demographic, clinical, or specific surgical factors. Out of the radiographic factors that were assessed, they did identify that decreased foraminal diameter and preoperative cord rotation are significant risk factors for this. And there's, within the same study was kind of a cadaveric dissection showing that the concern and why we think this happens, although there's many postulations, but that basically the extensive ligamentous support at the foraminal level predisposes the nerve root to traction injury after decompression is performed, especially from an anterior perspective. At this point, you certainly cannot reach or decompress these ligaments. And so this just shows that that ligament in the top right of the photo that, right now we kind of think these are traction-based injuries. So if we go back to our patient, hindsight, looking at her foraminal diameter, it's quite compressed on the left, 2.3. Some of the cutoffs that are described in various papers are 2.4 and 2.57 as a threshold that there's a significant increased risk. So it's interesting because on the right, it's 2.7, which technically is above that threshold, and then on the left, where the palsy occurred, it's there. And secondarily, I would say because of this unilateral central stenosis, that there is some cord rotation there because you can see the right portion of the cord is more ventral. So, in this patient, unfortunately, I think hindsight's 2020, I don't think much could have changed before this surgery other than counseling. I think a foraminotomy we discussed wouldn't necessarily be helpful. If we did this in every patient we thought might get a C5 palsy, you're likely over-operating. So I think these, again, are really difficult to handle.
Yeah, so preoperative evaluation of patient and post-hoc, shoulder arm immobilizer to take the tension out of the brachial plexus, even to the point of having a shoulder abduction splint, just when they're up and around and walking. And post-operative CT scan, obviously to make sure that there's not an immediate foraminal compromise. Rod, C5 acute palsy post-op came on a little bit late.
Yeah.
What do you do to take those back, or when do you take those back? Have you taken C5 palsies back?
That's an excellent question. So usually, if they have a painful, if they wake up with a lot of pain, typically we'll get a post-op CT to see if there's any residual stenosis. We do take them back. I think for me, a lot of them, if you just, they usually resolve and they get better. What's interesting in that paper that you showed, Nick, is that part of the myth with C5s is that historically we were taught that somehow it's a special nerve, it's got weird anatomy, but really it just comes down to it's more noticeable because usually it's the sole innervation near deltoid. And for most people, it's the sole innervation near their biceps. So when you knock C5 out, you take out deltoid and bicep, and that's why it's such a devastating injury. But unfortunately, I think it's something we deal with. Typically, if they get weak, usually the typical course is you don't see any changes on the EMG or intra-op, but then over a few days, you get a call from the patient, hey, I have this new weakness. Typically, we'll do CT, and then they usually resolve and they get better. I don't know what your thought is, Jens.
Totally agree. 3 to 6 months.
Yeah.
Bad prognostic factors are severe ipsilateral deltoid and biceps weakness, and diabetes, larger male body habits are bad prognostic factors, repeat EMGs at week 3 onwards, and despite questions of efficacy, I still use electrical muscle stimulation if I see it.
Yeah. I mean, this patient is a very high chance that you're going to get one.
All right, let's move ahead. Nice presentation. Thank you, Nick. And we'll ask Dr. Gold to come next. He was cut short the last time at STED Talk, so this time he's going to go first. And now this is going to actually test your electrodiagnostician skills. This was a fairly dramatic case. I think we handled it coolly, but tell me, as Colin's getting this up, what is the status of an electrophysiologist in our OR setup? Are you a practitioner? Do you work under the license of somebody? You have a technician in the OR. How is that kind of arranged in the overall care perspective?
Yeah, so the paradigm that we have in place is to be able to be in the OR as a surgical neurophysiologist, which I think would probably be our preferred nomenclature. You do have to get board certified, and that's done through through ABRET, which is the American Registry Board for Electroneurodiagnostics. And then additionally, within the general paradigm that we use, we also have a neurologist supporting through online. And so they're live, piggybacked onto the case. They're watching the case the entire time. And a lot of times when you're in the OR, you know, your primary communication avenue is going to be with the neurophysiologist that's in the room. But there's actually a little bit of a conference going on from their standpoint in terms of communications back and forth with neurology. And so typically you'll have multiple sets of eyes on the data set that's occurring. Now, the people that we have here, we have various skill sets and degrees. We have people with PhDs, we have people with bachelors, we have people with large wells of training. But for the most part, everybody, certainly on our team, is very well vetted and very well experienced in these theaters.
Great. But so there's a licensed practitioner in that whole team?
Yeah, absolutely. So we have the licensed practitioner from the physician standpoint with the neurologist, and then we also have licensure and credentialing that has to occur for the neurophysiologist that's in the room as well.
Got it. All right, to this case, this is a patient of mine, so I know it all too well, and Dr. Gold was with me in the OR, so first-hand report here.
All right, so this is a mid-60s-year-old man who presented to clinic with bilateral hand pain and paresthesias that have been chronic in nature. Additionally, complains of bilateral hand clumsiness, so poor dexterity, and neck pain. Patient works, or is a retired engineer for Boeing, and was in the Army as well, lives with his wife. Overall, very healthy guy. Physical exam, notable for some slight hyperreflexia in the triceps and brachioradialis. That's pretty much it. Otherwise, just numbness in the bilateral hands and fingers, non-dermatomal. Here's his imaging. On the left, you can see sagittal T2 MRI with mostly C5, C6, and a little less so 4-5 central canal stenosis. And then on the right is a CT scan with about the same cut showing this mixture of OPLL and disc osteophyte complex at those two levels, causing the canal stenosis. And then here are flexion extension x-rays showing preserved lordosis with extension and essentially normal movement, no spondylolisthesis.
So for me, Rod, I'll pick on you as a surgeon. I have never regretted getting a CT scan on a C-spine. I have regretted not getting one in years past. Does the presence of this heterotopic bone in the canal predicate you for one surgery versus another?
I mean, I think that's a really excellent question because I get CTs on everyone now. I think it makes a big difference in your pre-op planning.
And in terms of, you would not go anteriorly, right?
I mean, on this one, I think I would want to see the axials, but it looks like there's a big piece of calcified, almost like an OPLL type process occurring. So I would not like to go from the front.
I concur. This man is extremely fitness oriented. So he could probably, in his past, out or at least literally hang with our rock climber, Dr. Gold, who just survived a hair-raising, another ascent. I'm not going to go into details, but he is fine, and I'm very grateful that he sustained no injuries there. But this guy is super fit. He does not want a fusion. I see this increasing in our patients. They don't want fusions, and I actually respect that. But he had numerous surgeons tell him that he should have an anterior fusion done, and I, like Rod, but I'm not in favor of, first of all, disc arthroplasty here, and I cannot do a disc arthroplasty with this kind of a bone overgrowth. So we settled on what?
So C3 to C7 laminoplasty, and then I pasted the EEG summary here. Just to summarize, during the surgery, which was actually during the decompression portion, exactly as we were lifting the lamina, undercutting it with a curette, we had loss of left bicep, bilateral hands, left TA, and AH signals, which really did not return throughout. Sensory was unchanged by the end of the procedure.
So again, the exact point, and I really want to credit our techs in the room. They're superb. And we, I think, have a very good communication that goes on throughout. We have one of them sitting here with us, Jackie. They're very good. We had reproducible signals before. We talked to our anesthesiologists when we do the lifting of the lamina. We want the blood pressures to be above 85. We give a modest dose of steroids at the beginning, nothing high. And again, we use a very atraumatic technique. There was, at this point in time, no bump, no slip or whatever. We simply lifted up the lamina, and then we asked for motors, and there was a significant change, right?
Yeah. In this case, we already had the maps elevated. We didn't do preemptive steroids, but we did the stress dose of methylprednisolone.
After this, yeah.
Right when this happened.
Yeah. So we did not pre-load him with a high dose of steroids. We gave him, I think, 8 milligrams of dexamethasone or something at the beginning. A more standard surgical thing, but not a high dose. So we have a real problem here now. So can you put some words into what we're seeing here, and when is a change significant in your eyes as a senior electrophysiologist?
Well, I'll start at the end there, and I'll say that every change has some degree of significance. As to what that's attributed to, can vary from case to case. It can vary situationally in what's going on. But if we see a significant widespread change like this, and it is directly correlated with mechanical change that's happening from the surgeon's standpoint, this should raise everybody's eyebrows within the room, right? So this I would consider a very significant change, particularly given what the imaging looked like prior, right? So we think, okay, we have a patient who has a high susceptibility to intraoperative issues. Obviously, great care is taken, it sounds like, during the removal of the lamina, but nonetheless, I would consider this to be of a high degree of significance.
And what happened with the SEPs? Did they go down on him also?
It wasn't noted that they did, but I feel like I do remember that the SSEPs decreased when that happened.
And you'll probably talk about that in your lecture later, but tell us about the timeliness of SEP changes.
So in general, SSEPs are, so we have to talk about a couple of different things, right? So when we talk about, motor evoked potentials, SSEPs, and how we layer those two things together, and I'll be touching on this once we get into my chat, we really are looking at systems that are exclusive and segregated from each other, right? So SSEPs, we're exclusively looking at the posterior and the dorsal roots essentially, and then the posterior aspect of the cord, whereas with motor evoked potentials, we're looking at much more anterior distribution, and same thing for the nerve roots. Now, once we get into the RAMI and further downstream, the signals do start to get combined, right, in individual nerve fibers, but there's certainly exclusivity at the cord itself. Now, it's not entirely unusual for you to have selective issues within the pantheon of the neuromonitoring modalities that you have in play, and that can generate specificity. So if we have a change like this and we have no corresponding issues or changes with the SSEPs, then we're more likely and more prone to say, okay, this is looking like an anterior distribution only. Looks like it may be exclusive to roots, although in this it would be challenging to make that assessment because you have bilateral issue, right? So you're typically, whenever you have a nerve root injury, it's going to be much more lateralized in distribution. SSEP also differs from MEP in that it is a summated average response, right? And so within that, whenever we do a distal stimulation, you're basically activating the entire plexus network that is feeding into the cord, traveling up the cord, and then being recorded from the cortex. And you have to average many, many signals together. So if you had, for example, a selective injury to C5, like what we talked about in the prior case, on SSEPs, it may not show that because you're also aggregating information from the remainder of the cervical plexus, which can mitigate a very selective injury. Motors, on the other hand, tend to be more specific, but one of the problems we run into with motors is because they generate so much movement on the table, they tend to not get run frequently enough, right? So with SSEPs, we have a large cascade of information, and with motor evoked potentials, we only have information essentially on demand. And depending on the interval of how that's run is really going to dictate how much diagnostic valuation we can put towards that modality.
So the two things I want to pick up on here, then we want to move forward. So this was obviously one of those things that came out of nowhere. Let me harp on the line in the middle, which says, of which the surgeon was informed and acknowledged. So can you expand on that a little bit? What, when we see that there's a change, what should the communication be like from a neurophysiologic standpoint? What should the surgeon respond to, or how should the surgeon respond?
Well, communication's certainly a big hot topic in the OR, and I think that I would dial that back a little bit and say that we need to make sure that the communication that's put forth to the surgeon is actionable communication, right? And so if you guys are receiving very ambiguous information, we think there might be this, could be this, that's going to really impact your ability to suss out exactly what that messaging means and how to react to it and what should be done. From a general communication standpoint, I would inquire as to how do the rest of the modalities look, right? Do we have corroborating evidence in multimodality testing that says that this is specific, or are we thinking that it's more central cord? Does it look like what you would assume for maybe, something along the lines of a reperfusion situation that's very selective, or is it something otherwise? Is it something systemic in the environment? And that two-way communication, that closed-loop communication, is critically important. And it's a shame that it gets boiled down to, a single sentence like that in the report at the end.
I'm also angling at checklists. So this was something where our partner, Dr. Amir Abdul-Jabbar, wrote a very nice paper in Spine a couple of years ago, where based on a questionnaire situation, he elucidated kind of a checklist. I think, to my knowledge, it was the first such article. It's been replicated several times. Where are we now with a checklist kind of a response? Sorry. As to critical neuromuscular changes.
As of right now, no one has looped me in on that, and so I'm not overly aware of that. I think that there's a large degree of variance within the world of neuromonitoring, and that in and of itself can be a problem, right? So, who shows up to the case, what their skill level is, there's not as much standardization as we would like to see. I would be a huge proponent of moving things in that direction, and I think that general standardization within the sphere of neuromonitoring would be beneficial to everybody involved and create a unified language, right? So that we're all working off the same playbook and that everybody is digesting information and everybody is receiving information in a much more homogenized format.
Dr. Skuyan, tell us neurophysiologically what happened to the cord here. Assume there's no trauma except for the lamina was elevated, the ligamentum flavum was released, there was no, to repeat that, bump, bounce, push, whatever.
I mean,
motors dropped bilaterally in some areas, and SEPs stayed intact. What happened to the cord?
So I'd love to see the Cadwell, the free, when you can stimulate and see what happened. Losing motors, I have to think this is real, because just because of how much stenosis there was, maybe there was a little bit of reperfusion that went on after, it happened after you did the laminectomy?
It was almost immediately,
Yeah.
like as the laminectomy.
Yeah, I mean, I think it's probably real. I usually, again, I kind of just, whenever I see a significant change like that, I step back and then I go to the monitor in real time with the, whoever's in the room, go over, look at the baselines, look at what's going on. And for me, the important thing here is the SSCPs. So as long as those are fine, usually the motors might not come back. But to me, that's more of like just understanding the neurophysiology. You've got your cortical spinal tracts. They're very sensitive to reperfusion. And once you lose motors, it's hard to get them back. Whereas the dorsal column, they're much bigger. They have way more, the neurophysiology is, they're more robust. So as long as I have SSCPs and I think it sounds like the motors never came back, right? Or did they come back after?
Fully.
Not fully, yeah, they're still reduced at the end.
I would, just to chime in really quickly, I would agree with that wholesale, right? So when I see something like this, my assumption right out of the gate is that it's a real physiological change. Now, the way that we layer multimodality testing together gives us, really good information in terms of if we have preservation of the SSCPs, and this is a posterior approach that we're talking about here, we know that we have a reasonable degree of intact functionality from the central cord standpoint. Right? Motors can be very fickle. And that then turns into one of the things that's good about motors is that they change quickly and they're very responsive. Sadly, they're not as responsive on the return as they are on leaving.
Yeah.
However, we run a full set of motors, right? And so when we say that we have losses here, if we have preservation of anything in the legs, right? So here we say that it looks like diminished within that, but we know that there's pathway availability, right? And pathway availability is actually a pretty good concept to be familiarized with. And so when we say, okay, this person had a physiological event in surgery, but do they demonstrate pathway availability? And that's going to tell us that these areas are still connected to each other. Right, and so the likelihood that they may have a postoperative deficit is statistically higher as a result of this happening in the OR. But if they maintain pathway availability through that, their likelihood of that being a transient deficit is higher, and the likelihood of that being responsive to rehab in postoperative care is also higher.
Great points. Let's take us forward, Dr. Gold, toward the conclusion, because we have 4 more cases to go through.
Okay, so patient was admitted to ICU post-op for MAPS greater than 85 for 24 hours and 24 hours of methylprednisolone. Patient was completely neurologically intact from waking up to the time he left the hospital on post-op day 2. At the long-term post-op visit, he reported persistent numbness in the right fingers and balls of the feet, electric shocks in his legs, which were a new sensation. He had another EMG post-op, which identified moderate sensory motor polyneuropathy with axonal features in the bilateral lowers, which was something that was new on the post-op EMG, although I don't think he had a pre-op one. So this was just kind of a second problem identified. Here's the post-op imaging. He did show up with an MRI in an ED somewhere because of post-op dizziness, I think he was having, vertigo. It just shows a mild fluid collection, but good decompression of the cord. And then on the right are the longer-term post-op x-rays.
And so functionally, he did quite well. It did cause everybody involved some anxiety. Obviously, as a surgeon, you kind of go into this kind of a deep fog of what's going to happen to the patient. You just stay with your training and do all the escape measures. We gave him high-dose NASCAs. We put him into the ICU for monitoring. We got a postoperative immediate CT on the way up to the ICU. There's nothing offending the cord. This, to me, is what Dr. Osgoon described, a reperfusion trauma. We've seen that the timing of motor recovery, I've heard this is a big deal. So if people start getting some motor recovery back within a certain time period, and I'll leave that time period open to you to comment on, that's an encouraging sign, even if it doesn't reach baseline robustness. Can you talk about timeliness of motor recovery when this is, again, a near miss or?
I mean, sooner is better.
Yeah, I always heard like half an hour to 45 minutes recovery is a good sign. Is that?
Yeah, no, you're talking about once we get into post-op?
No, right in surgery.
In surgery.
After there's some event / insult.
Yeah.
There's a time correlation. Sooner the better, of course.
Yeah, there's a time correlation, and it's not as well defined as I would like for it to be, right? I would like to see large scale case studies with this and publications to where this is really sussed out. In general, one of the things that we want to look at is, I think that, a half an hour is a realistic benchmark in terms of, what we see for normal and natural recovery of motor fibers that have been impacted some way, either mechanically or systemically or otherwise. But to your point, I mean, and what I had mentioned earlier, what we really want to see is pathway availability at the end of the day. And, unfortunately, a lot of times when we get to this particular portion of a surgery, there may not be a ton of time left on the clock in the OR, right? And so we don't always have the amount of time that we would like to have access to be able to see those returns.
So talking about time on the clock, we're 20 minutes away from your lecture, and we have 4 cases to go through, and freshly returned from Rio together with our team, where we had, I don't even know what, 8, 10 presentations or so. Dr. Hogshead did a terrific job presenting some of his research there amongst 2,000 people at the Global Spine Congress in Rio. He's still a little bit jet lagged. I saw him just yawning. I'm still a little bit jet lagged myself, but Cameron, take us through 2 cases.
Long trip, but a good trip. Well worth it. This is a 61-year-old male with worsening low back pain and right lower extremity radiating pain that came in, and you can see his lateral lumbar x-rays there. Back pain was progressively worsening over the last few years. When he saw us, he had pain basically in the L4, L3 distribution going down his leg, and worsened after about 2 to 3 blocks worth of walking, and just became intolerable, even intractable to all the conservative measures listed there. He had a 3/4 transforaminal epidural steroid injection, which gave him pretty significant relief for about 2-3 weeks, and the pain just returned back with a vengeance. His past surgical history had iliac artery stents placed. You can see there on the lateral, and he's currently on Plavix, and that medical history there. Pretty active guy, enjoys the outdoors here. No bowel or bladder symptoms. You can see his motor exam there, no motor sensory deficits, BMI of 32, moderate to severe disability on ODI scores. We had gotten flexion extension x-rays of his lumbar spine, and you can see an obvious spondylolisthesis there at L3, L4 with instability, and also noted bilateral pars fractures. Here you can see an MRI cut, axial as well, of the L3, L4 segment. A lot of neural anatomy and vascular anatomy and that you can pick up at this particular level, especially if you're considering surgical options in the form of anterior for this patient, which is something that we were considering in this particular patient. You can see the segmental artery anatomy here, which is very important to note, especially on the lateral, to make sure you're not running into any vascular structures or danger when you're approaching this from a potential lateral. And then you can see the main vessels there out of the way at that 3/4 space. And you can also note the psoas and the plexus anatomy as well. As you go towards the further caudal segment of the 3/4 space, you can start to see a little bit of a Mickey Mouse ears and the lumbar plexus creeping anteriorly, but not particularly prohibitive in this case.
So let's move forward. So this is a L3/4 ischemic spondylolisthesis, grade 1 severity, foraminal disease, no central stenosis. I do not like the aortogram. This kind of calcification is not so hot, so we'll give him surgery. I'm personally not at all in favor of going anteriorly in a patient with a calcific vasculature. I think I know this is not my patient what's being done here, but I would be perfectly happy to suggest this patient a posterior open reduction with decompression L3/4, a single level instrumentation with an intradiscal osteotomy for a nice lordotic stable realignment. Dr. Skuyan, would you venture for a far lateral procedure?
I would do a Coflex.
That's contraindicated for ischemic spine.
Kidding.
Nice try.
I think that's That's a reasonable approach. I do think lateral might not be a bad option here too. One level lateral and then do perk screws from the back.
Yeah, so that's what we proceeded with. In this particular case,
nice.
it was a prone lateral at the L3, L4 level with just solely relying on indirect decompression, perk screws in the back, no opening from posterior, and then a large anterior cage that was placed. You can see our intraoperative x-rays there.
So there's no posterior decompression done. This was percutaneous screws?
All percutaneous screws, no opening of the posterior.
Okay.
And this was single position surgery with prone lateral. And this kind of just brings into the discussion of the evolution of lateral surgery. And you can see there the dreaded plexus and what you're really fighting and going up against. And when you look at that MRI, considering your treatment options, yeah, if you're just going posterior, all of those discussions we had, you don't really have to worry about. With a lateral surgery, you got to look at the aorta, the segmental vessels, the plexus, this plexus right here you're looking at here, even at the 3-4 level, which in this particular case, and performing surgery, it was very difficult to find a good docking spot because the lumbar plexus was getting stimulated with trigger EMG, which now we do use in lateral surgery. I know back in the day, Dr. Askewian was dissecting out the plexus and using a microscope, as he said before. Intraoperative neuromonitoring really made a huge evolution in technology to where we can actually trigger where our nerves are and map out where the plexus is.
So I just want to credit this image is from our former fellow, Dr. Perry Godolias, who is now back in Germany again. And this was created by him in a 3D printing format from a regular MRI scan on a patient. These white things that you see there, these are the actual discs. So the vertebrae are basically digitally subtracted. And the red image on the right is the psoas, and the one on the left side shows the psoas stripped away. And the inference there, Rod, I think you as excellent expert will concur, the lower we go below L3-4, the more we get into deep trouble, right?
Yeah, I mean, actually, you can see there, L4-5, that's a great lateral view. You can see all the nerves just right in the where you're going to do your lateral approach.
Mm-hmm. So, Dr. Morrisette, Nick, this is now one of those controversial areas. There are a lot of companies who now offer surgeon monitoring technologies to map the nerves. What are they doing? What are they selling? And how good is that? How meaningful is that?
I'll try and be somewhat politically correct, but I'll just start off by saying I'm not a fan of that. I think that typically the product that you guys receive on the back end of that is typically not as robust as the amount of risk that is entailed in navigating this. And this is a wonderful image that really displays that. And so what you'll get a lot of times is a very sort of a bare bones, sometimes automated, sometimes not automated system that is, essentially trying to do a reasonable job of mimicking what we can do whenever we have staff in the room.
And these are not motor-based, these are SEPs, or how do they map that?
It depends on what product you receive. I mean, when I look at this, what I would say is that you want to have SSEPs, right? Of course, you want to have targeted EMG for scouting out where the plexus lies, and then how much expansion you can get once you actually get in there and start to create your tunnel. In addition to that, these cases tend to do very, very well with saphenous nerve monitoring in SSEPs, which has been proven time and time again to be a terrific indicator of both whether or not you are causing direct mechanical impact to the nerve. The other thing that with these approaches to open up the angle as much as possible, you can also introduce the likelihood of a stretch nerve injury, and saphenous SSEPs in these particular cases is an outstanding indicator for that.
Mm-hmm. So, Dr. Abdul-Jabbar, are you live? He was a surgeon on this, because I guess there were some problems with monitoring there.
Yeah, they're docking in the disc space appropriately with getting
Here he is.
high enough numbers in this case was noted to be a little bit more
You're
challenging.
color coordinated. Your shirt matches that of our speaker.
Looking good.
It's bland.
Yeah, I just wanted to mention, this one, although the patient did well without any postoperative, bad paresthesias, which we see pretty often with these lateral approaches in the anterior thigh, or any, femoral nerve weakness is something we worry about. This was one where, at 3-4, we tend to see that less often. But despite that, it was a little bit challenging getting an appropriate docking spot because there was, quite a bit of firing. And so we had to kind of readjust our approach, take a more anterior docking spot, which we did find to be safe. And, you want to be very timely with your work in that disc space when you're, just because you find a safe corridor anteriorly, it means you're probably pushing that nerve back. So you do want to limit the time that you have that retractor open. And fortunately, this patient did well. But again, worry about the limitations of, the system we were using was only EMG and SSEP. So, wonder about the presence of motor evoked potentials in a lateral surgery and how valuable that would be.
Great, so let's move forward, good points.
So patient did well, as Dr. Abdul-Jabbar said, a 1 or 2 day stay in the hospital, nicely realigned spine there. And this is a 1 year out. He's doing well with pretty much symptom resolution.
Nice, okay.
Next case is a 65-year-old female with worsening low back pain and left lower extremity radiculopathy. You can see a pretty dramatic lumbar spine lateral there with L5, S1, isthmic dysplastic spondylolisthesis, which is near spondyloptosis. She'd had back pain since about age of 22 after noted pregnancy. She was a gymnast in the past, never really experienced pain there. She had tried all of the conservative management upon seeing us. She did have some deficits on her exam with some L5 nerve root weakness bilaterally and correlative sensory changes. Here you can see how flexion and extension views pretty dramatic instability of that L5 S1 level.
So this qualifies as a loptosis, actually. So this is grade 5 or beyond grade 4. And she had, what was her neurostatus?
Yeah, she had some L5 nerve root weakness coming in. She was about, her EHL was 4 out of 5. Say her ankle dorsiflexion was 4 out of 5 as well. And she had some sensory changes in that L5 as well.
So we talked about surgery and we did surgery, and what happened?
So this is something you can't, probably not recommended anterior or lateral. It's a posterior project. You'd see CT scan. Also, those L5 notorious traction end plate osteophytes into the foramina. And we did a posterior-based single midline incision, open reduction with bilateral cages and intradiscal osteotomies to completely free up and release the bilateral L5 nerve roots. And you can see also special care was taken to really remove those L5 inferior end plate traction nerve roots that were going into the foramen. Noted during the surgery, there was no lasting SACP or EMG changes. You can see CT hardware all looks in appropriate placement. Excellent reduction of the spine there with cage placement.
And neurologically, the patient did?
Neurologically, the patient woke up with bilateral L5 nerve palsies.
Worse than before?
Worse than before. She was 2 out of 5. Previous before, she was about 4 out of 5. Trying to move this forward, sorry.
She has actually excellent hip abduction, but this is deeply frustrating. So L5 palsies next to C5 palsies are my nemesis, because again, we've done everything. We've done direct nerve monitoring, we've done the motors, and I obviously, when I do it very diligent, I think tell patients beforehand, sorry, the Rio is still in my throat, or the flight. I tell patients there's a 10 to 15% risk of a L5 palsy, temporary or permanently, unilaterally, bilaterally, and she falls into that category. She had a bilaterally, but there was nothing in surgery. There was no, again, slip, bump. The reduction itself after release was very cautious, and one thing that I've learned over time is to knock off that inferior, do you mind putting your cursor on that lateral, on that inferior vertebral body of L5? No, just go, yeah, that lateral view showed. We try to knock off as much of that inferior rim of L5 because I think that was prognostically a bad thing. We went as far as I could to kind of open up that foramen. That root was circumferentially loose. It's not tight. Yet she had what looks like a tension thing. Thoughts, how can we monitor L5 better?
It's a tough one. You're bringing the challenging 5 related questions today, which I appreciate, but I wish that there was a greater degree of consensus, again, where I could say, do this and that will, have your risk, right? Unfortunately, I think that there's no such thing as a risk-free surgery, and unfortunately, these types of cases really demonstrate that. Perhaps in the future we'll get to a place where things are advanced enough or make advancements to where we can get to a place and say, okay, this is almost certainly the causative factor of what's going on here. And these are the confounding cases that, they're very frustrating from a neuromonitoring standpoint as well, because we want to provide a service to where we can give you the information that is actionable information and where it's a one-to-one. And sadly, in these types of cases, whatever the physiological root cause of that is, it continues to be elusive.
Yeah, this is, again, and we've had, just like in the C5 palsy, we've had delayed L5 weakness after surgery. Again, I've done motors in the past. I've done the direct nerve monitoring with the little probes on them. This is something where we could change things in surgery. We could reduce some of the reduction. We could reduce some of the distraction. If there's an impairment, again, it's pretty frustrating. Rod, any thoughts on L5 palsies, and should we not reduce them?
I think it's similar to C5. I mean, this is a beautiful result, and I would say that you're going to expect, she's going to wake up weaker. I'm sorry, but that's just how it is.
How does she do long-term?
These are her 3-month x-rays. She does feel objectively that she's improving with her strength, but she's subjectively still about
She'll get stronger.
motor grade.
Yeah.
Anti-gravity, like 3 out of 5 bilaterally with ankle dorsiflexion.
Yeah, pain-wise, she's very happy with the surgery, but functionally, she's clearly weaker than her impaired state before was. But it's, again, hard to measure because she literally could not walk. She was kind of in a wheelchair hobbling around before. This is a pretty dramatic and actually also progressive spondy. So
Yeah.
We do Mark's case.
yeah, let's do Mark's case. Thank you. Last case, and then we'll switch to our lecturer. Thank you, Cameron. And not from Rio. He stayed behind, held down the fort. Our future partner, Dr. Mark Kramer, neurosurgery training, Wisconsin, and he has 1 case to show. You have 2 cases, but let's just focus on this case.
So I kind of put these cases side by side to kind of create a little discussion, but long story short, we got 2 tumors here. First one's a 65-year-old lady. This lady presented with leg weakness. Her symptoms began almost 9 months before she ultimately presented to us. And dating back to, again, almost a full year before, she was ambulating, no problem, just fine. In fact, took a trip to Europe and was walking miles and miles a day. But by the time she got to us, she was essentially wheelchair bound. Not too significant past medical history, no history of any spine surgery. Still active. This is the exam that we initially saw her. This is a couple of weeks before her surgery. And unfortunately, this exam had actually deteriorated even further in the few weeks that it took to kind of get the surgery approved and scheduled. So again, by the time that she presented to us, her right leg was very weak. Her hip flexion at the knee was about 3 on the right, and at the hip she was about a 2. So she was basically unable to ambulate at all. Left side was a little stronger, but weaker than shown here. Here's her imaging. You can see this pretty large tumor sitting right behind T6. And just briefly on this as well, we didn't have a CT on this one, but there is this kind of dark signal posterior to the tumor itself, the lesion. It is causing significant mass effect on the cord, of course. And we interpreted this as a pretty large calcified component of the mass with what classic appearance of like a dural tail on this lesion. And then as a follow-up, kind of as a comparison case, another woman that we recently operated on, this woman's about 10 years older. In this case, this lesion was identified, interestingly, on a routine scan that was done for other reasons. So she had a chest, abdomen, pelvis scan that was done for other reasons, and they found this calcified lesion behind T6 in this case. And in this case, again, no previous spine surgery, but she had pretty mild symptoms, just some imbalance. And her primary doc ordered, so full strength on her exam, just some mild incoordination and imbalance. And here's her scan right here. So lesion here between T8 and T9. Similar appearance, kind of a dural tail, classic appearance of a meningioma. So
And obviously you'd have done full neuroimaging, so neural axis, brain, C-spine, L-spine, everything.
So just as a kind of comparison here, case one, quite severe symptoms, essentially wheelchair bound. Again, appearance of a drill-based mass behind T6. Second case, also a drill-based mass, a little lower in the thoracic spine. I guess the question is, how can neuromonitoring be helpful in these cases? What would you expect to see in terms of somatosensory evoked potentials and motor evoked potentials in either of these cases?
My general expectation for motors would probably be that it would line up with what we would see from the myelopathic symptomology the patient has, right? So if they're having significantly progressive weakness, I would expect that to be reflected on the motor evoked potentials. In all likelihood, we would be able to develop waveforms on that side. I would expect them to be lower in voltage and potentially transient in nature comparative to what the left would look like. Although in this case, both of these, when you look at the imaging, there's really significant displacement and compression in the canal on the cord. And so, when we walk into that, we say, kind of everything's on the table as to what we're gonna find from a neurodiagnostic standpoint. As to how it can be helpful and can be used, I mean, there's many different modalities, there's many different approaches that can be used on a case like this. I would certainly do really everything we can for central cord monitoring. We're gonna wanna look at SSEPs, we're gonna wanna look at motors. We're probably gonna wanna have pretty heavy distribution for muscle pathways in the lower limbs. Also, because when you talk about thoracic tumors and thoracic canal stenosis of this size, we're also going to be very concerned about what the perfusion pathways look like there, right? And so general perfusion for the thoracic cord is always going to be lower than where it is cervically and lumbar. And so as a result, we would keep a very close eye on blood pressure throughout the case. We would be working very much in concert with the anesthesiologist to maintain that. And be very sensitive towards changes.
That's a good question. I guess the next follow-up question for me is, I know D-wave typically used for intramedullary lesions, but is there any role in a case like this? What's the most sensitive type of modality in the case of more of a compressive pathology is what we think is going on in this case?
I mean, you could certainly do D-waves on a case like this. I think the T6 is maybe a little bit of a better candidate for that. Utility for D-waves, it starts to get challenging as you get into the lower thoracic. And then, of course, anything lower than the conus is obviously not even going to be an option when we talk about D-waves. But I do think there's utility in that. I think that this may be a case where I would probably throw as much as we could at it from a preparatory standpoint. Because the more you can overlap your data sets, the more then you can look at the nuance of how the data is being displayed to you and really perceptionally, what story is that telling for the case?
So just to give you, I guess, some hindsight behind both cases. So the case on the left, the larger tumor, the more symptomatic patient, her monitoring demonstrated very unreliable SSEPs bilaterally in the lowers right from the onset. And she essentially had absent motor evoked potentials. So kind of a challenging case, I guess, similar to what you'd expect based on her preoperative exam. Whereas in the second case, the case on the right, the T8-9 tumor had essentially intact SSEP and MEP monitoring. Thank goodness. So we resected both these. We did a thoracic laminectomy and microsurgical resection of both tumors. I have a short video to show from the second case, but both patients woke up at their preoperative baseline. I think, at least from my standpoint, the monitoring, I think, is helpful because you at least have a baseline that you can work off. And, I think having a regimented timeline in terms of when you're running your motors during the course of the procedure is helpful to know, at what point you might have caused a potential issue. I guess the question is, in those cases where you've got severe cord compression and, unreliable signals or absent signals, what other tools can we use? And should we have changed what we did on that first case potentially?
I mean, not necessarily. I think that, again, for cases like this, D-waves can be nice because you limit all of the sort of confounding factors once you get the brain involved and all this, right? You're just looking for direct pass-through. Can I send information from one side of the tumor to the other side of the tumor, right? And again, that touches on pathway availability like I talked about earlier. And when we can demonstrate that's good. Now, when you get a patient who is very severely symptomatic, you set up for monitoring, you go into the room, you don't really have a lot, right? We can still use monitoring there as a way and a means to, are we getting restoration of any type of data or waveforms, right? So now motor evoked potentials, we talk about the general sensitivity of them, how difficult it can be to get them to return within the time frame of the surgery if they're already impacted. But SSCPs, on the other hand, tend to be quite a bit more resilient, right? And so in a case like this, you go into it hopeful to say, hey, we hope we can create a good data set to be actionable off of. But in the absence of that, we can also still look for improvement throughout the case as well, to signal that things are going in the direction that we want them to go in and have a higher likelihood of this patient having a good post-operative outcome.
So, Dr. Scoot, in this beautiful case, you have very nice dissection. So tell us a little bit about your preparations like high-dose steroids, MAPs, and tell us about how you use monitoring intraoperatively in terms of your surgical approach and radicality of resection, et cetera. And if there are changes, do you slow down or what do you do?
I mean, this is an extramedullary tumor, so it's a little different. I'd say I'm not as concerned with the neuromonitoring and the changes that occur. The intramedullary ones are a whole different ball of wax, and so, I think for intramedullary tumors, you absolutely have to, every move you make, you have to stop, do a run. I do think D waves do add some value, but, just depends on the location and what you're doing. I think, in my experience, these cases are extremely challenging. In some ways, I would say in neurosurgery, it's probably the most challenging, even more so than, I'd say it's in the whole, brain stem area. I mean, there's just no room for error. So if I'm doing an intramedullary spinal cord tumor and there's changes, I stop. Sometimes you have to wait a little bit. But if I lose signals, I just close up and get out. There's no, unfortunately, you gotta just, it's like flying a plane. You want to decide, do you want to do a crash landing or do you want to fly the plane safely? And I've actually abandoned, like mid-surgery, I just stop. This is where I think, you can poo-poo neuromonitoring all you want, but for intramedullary tumors, it's actually pretty important.
No doubt. Dr. Luis Quartararo, thank you for always watching so faithfully. He wants to know how you close the dura and do you do an expansion duroplasty or something like that?
In this case, we just closed it primarily with Neurolon and got a pretty good resection. So sometimes we do have to do a duroplasty.
Do you do a patch graft over it, anything like that?
Not in this case, we didn't, no.
Okay. Great case. Thank you to our fellows. Great cases, great discussion. I want to recognize our friend Chris Schuhart, who's here in the electrophysiology world as the leading, now retiring or soon retiring bone physiologist. But nice to see you. Dr. Nick Morrisette is a neurodiagnostician. I'm still in the Brazil fog, I apologize. He originally trained in Pittsburgh, Pennsylvania, and he's been a well-known fixture in the Pacific Northwest in terms of neurodiagnostics, and has worked in the Providence St. Joseph system. He's also an MHA and has shown leadership function aside from technical expertise. Come up to the podium if you will. And, oh, you're going to help us. Wonderful, Corey. So thanks for being here this morning, and you saw some of the things that we're troubled by. There's still plenty of things that we can work together, but curious to hear your thoughts, and your comments already were really cool. So thanks for being here this morning.
Yeah, thank you for having me. All right, you guys able to hear me okay? All right, perfect. So one correction that I have that I'm always seem to need to make, I am not a doctor. I just spend a lot of time with them. All right, so, but I very much appreciate being here. I appreciate having a venue to chat with you guys. So I thought long and hard about what I wanted to talk about, and I thought it would be good to talk about, you know, everybody in this room is somewhat familiar with IOM, but how can we maximize that? How can we really create this and make this a stronger tool in your toolbox to navigate your cases? So I wanted to do a quick overview of IOM. So essentially we're looking at using electrical stimulation to monitor diagnostically what's going on with the physiological state of the patient's nervous system throughout the surgical procedure. It is important to note that we do not use this to create a diagnosis for the patient. We're not comparing this to normative values. We're comparing these to prior values for that same patient. And one of the things that I think came up a little bit in the case reviews that we had is we always appreciate it whenever there is preoperative diagnostic tests done. So preoperative EMGs, if we have any ability to have preoperative data, we really cherish that, and we like to have it. Again, we work off of baselines that are generated by the patient's physiology prior in the case. We use our electricity. I like to throw in some slides to have a little bit of fun every once in a while. Some of the older folks in the crowd probably know exactly what movie this is from. I see some head nodding. And of course, this is our goal at the end, is not only that it's alive, but it's functioning the way that we intended to. So one of the modalities that we use, I try to keep this very relevant to spine, so I try to leave out all of the intracranial type of work that IOM does and neurophysiology does. SSEP potentials are one of the modalities that we use. Where are we at here? There we are. Okay, sorry about that. So SSEPs, these are looking at the afferent pathways, the peripheral and central nervous system. It is important to note that we are essentially looking at the posterior derivations exclusively when we talk about SSEPs. Now, SSEP waveform, these are summated averages, is what I talked about previously, and there's advantages and disadvantages to that. The primary advantage to that is that it develops a really high degree of resiliency to it. Another thing that's a huge advantage of SSEPs is we have the ability to basically run these continuously throughout the case. So we get a continuous stream of data from SSEPs that has a tremendous amount of utility. Oftentimes we're using multiple stimulations, hundreds, depending on how much noise is in the room electrically, depending on you know, what the quality of the nervous system is of the patient. These are our ascending sensory pathways. I'm sure that everybody in the room is very familiar with this. Of course, you know, I do like to throw in a little bit of humor from time to time. I think you guys are picking up on that.
That's very good.
Yeah. So now I pulled data. So when we talk about SSEPs, I want to give you guys a little bit of a look behind the curtain, so to speak. And this was from a recent case. And this I really love. So we were looking at basically a cortical response on the left, a secondary cortical response in the center, and then the subcortical response that's generated from the brainstem, typically in the pyramids, as the data decussates to the other side. Now, this demonstrates utility beyond, you know, discretely what's happening for a surgical event. This was a positional injury that was picked up as the patient was being placed on the table. If you look at where the arrow's at there, we can see a significant decrease right out of the gate of the SSEPs for this patient. The room was notified of this, the patient was repositioned, and a brachial plexopathy was avoided. And so this was a posterior approach, patient's in Superman position, and of course, you know, we have concern about that. We always figure we're in the room either way. We may as well develop as much data as we can and as much utility to the case as possible. These types of injuries typically occur around the 90-minute mark, but this is a good example of it happening almost immediately. We can see that this was a multi-hour case. Had this not been picked up or had it not been acted on, the likelihood of a patient having a incidental injury from positioning in the OR would have been exceptionally high for this individual. So that's good utility for SSEPs outside of just, you know, is the central cord functioning the way that we want it to? And that brings us to transcranial motor evoked potentials. So these are looking at the integrity, the efferent pathways, the peripheral nerve, central nervous system. Again, this is exclusive to the anterior aspect of the cord and the ventral roots. And it is important to note that you can have selective changes. We can have changes that are exclusive to those pathways that would not be displayed on an SSEP. One of the really good pluses for motor evoked potentials is that they have a high degree of sensitivity, they have a high degree of specificity, but one of the downsides to that is that they're not a summated average, they aren't run throughout the case. And so one of the things that we can run into trouble with motors is if there are long intervals between acquisition periods. Right, so I know some surgeons will do, you know, run a motor at the beginning of the case, run a motor at the end of the case. Okay, well, what happened in between, right? So we really need to be mindful of the idea that this is an on-demand modality, and we're going to get a much higher degree of valuation out of it as we use it more frequently. So here's our descending motor pathway again. I'm sure that these are images that everyone and pathways that everyone in this room is very familiar with. However, it did give me a good opportunity to throw an extra pun at you guys, which I'm always a fan of. So this, I wanted to do a little bit of historical perspective. And again, this is a little bit of a look behind the curtain. So this is what motor evoked potentials used to look like. And this is a very good representation of that. Typically, this is what we look at. We like a black background because when you're sitting looking at a screen for, you know, anywhere between 2 and 10 hours, a little bit friendlier on the eyes. The much lighter response that we see is our baseline response, and then the more lavender response is the up-to-date response. So that's our most recent set. This was a really good case. This was representative of a significant improvement for this patient in their bilateral triceps, and this was a low cervical case. Now, this again is how motors used to be run, and I wanted to show you what motors look like nowadays. And this is a little bit of an advancement that we've had on our end, where now we look at both sides of the body for every stimulation. And we learned that if you run motors at too high of an intensity, you can bypass the cortex and directly stimulate the subcortical matter. And then you essentially will have crossover to where you're activating both hemispheres at the same time, and can lead to an incidence rate of either false positives or false negatives. So nowadays, we look at both sides of the body for every stimulation set to ensure that we don't have that crossover. So again, a good example of really finely tuned motors and, you know, how we want to see things nowadays. EMG, we touched on a little bit earlier. I think that EMG is sadly taking a bit of a back seat to some of the more flashy modalities, such as motors. Of course, SSEP is our stronghold that's been around for forever. But there's a lot of information that we can get from EEGs or from EMGs in the operating room. This looks at, typically we're going to do passive recording of EMG. We're going to do stimulated recording of EMG. And so the passive elements of it, we can see if there's any type of mechanical involvement with the nerve structures that lead to those myotomes. We'll typically get an EMG response. We can grade that based on, is it a large burst of EMG, which tends to happen most frequently whenever we have a mechanical trauma to the nerve, or we can see a train, as we alluded to earlier on the EMG, which will let us know that that nerve has been irritated. There's some process in play. And if you're doing a large spine case, that may be an indicator for you to move to a different area. If you can for a while, let those nerve structures calm down a little bit, let them recover. And typically we'll see that within a course of a relatively short amount of time, right? So if you get a big train of EMG, maybe you're working on getting an osteophyte out of foraminal space or whatever the case may be, when you get that train of activity, it's the nerve essentially telling you, hey, we're getting quite irritated here. You can move to a different area, and that really actually does reduce the incidence rate and likelihood of whether or not the patient will have any type of postoperative deficit relevant to that myotome. So multimodality testing, I touched on this previously, and this is, as we said, with the SSEPs and with the MEPs, they're very segregated systems, right? And so if we're only looking at one, we develop a blind spot. And so we try to layer our testing together in a very concise manner that's very targeted to the specific surgery at hand so that we eliminate those blind spots. And again, this is sort of why we want to make sure that we're running motors at a more frequent pace with much smaller timing intervals, particularly during the real sensitive parts of the surgery. Because if you're not looking at that, you do have a blind spot as to what the anterior functionality of the cord is or what's going on with the ventral roots in the area where you're working. So interventional windows, this is an important concept and I think doesn't get discussed enough. And, one of the things that we really want to achieve within the realm of surgical neurophysiology is providing information that creates an interventional window. We want to provide information that is actionable to where you can say, okay, we've developed a problem during the course of this case, we'll create a correction, we will intervene on that problem and either eliminate or completely remove any level of postoperative deficit for that patient. And this is a huge improvement over how surgery was done in the past. And now at this point in time, that's the distant past, but sadly there are still, places and areas, as Dr. Chapman alluded to, administration wanting to cut costs, neuromonitoring always seems to be under the axe for that. But we want to make sure that we have these interventional windows because it's just better for our patients. We want to avoid long intervals between data collection, and this is how we create those interventional windows. If we have a data set that we do a baseline at the beginning of the case, and then we do a data set at the end of the case, and a vascular insult happened at the 40-minute mark, and we closed at the 3-hour mark, your ability to go back and correct that basically doesn't exist at that point in time. And so we really want to leverage this as a tool to make sure that we're creating these windows and that we're acting on them. So we want to optimize our stimulation parameters. I know that sometimes there can be a general thought process that, oh, well, this is the maximum voltage that we should use for this, or this is the maximum current that we should use for this. And there's a lot more that goes into that discussion as opposed to just a raw number. And we want to always understand that each patient's nervous system behaves differently from a neurophysiology standpoint, and they have a different excitatory parameter in terms of what is the correct amount of stimulation for them. We also can talk about Ohm's law, but that's, outside of the scope of a 30-minute talk. But, just saying this is the voltage number, it doesn't tell the complete story. We need to know what the voltage is, we need to know what the current is, and we need to know what the impedance is to be able to optimize things specific to that patient. Communication, we did touch on this a little bit earlier. I could have put together many more bullet points here, but it's early in the morning and bullet points are, we don't want too much of that at this time of the day, but the top comment is something that I will always stand by. The IOM data will only ever be as useful as our collective ability to communicate. If we have the most amazing data set in the world and the anesthesiologist says it's fake news and the surgeon says, I didn't do anything, it wasn't me, we're not really going to develop a lot of high quality access to interventional windows from that. We're not going to be able to leverage this as a tool set the way that we want to for our patients. I would say that in general in communication, we want to try and work towards closed loop communication. Makes me a little sad that Yubi isn't here today, because I know that he would be a huge proponent of this, given his military career and otherwise. And when we talk about closing the loop, I can tell you a 20-year career in the OR, there's been certain times where, hey, there's motor changes. No comment. Hey, there's motor changes. No comment. We need acknowledgement, right? And I think that if you really want to leverage IOM to its maximum capacity, you want to collaborate with your team. You want to have them invited into the process. We love to be a part of the process, and we can give a tremendous amount of utility above and beyond what is just sort of the baseline thing. And when we talked earlier about, hey, how do we feel about these automated devices that are coming in, surgeon-driven IOM, that removes this entire communication layer from that, and it removes an entire layer of expertise that you have at your fingertips and should be utilizing to create more consistent outcomes for your patients. So what's the point of all this, right? Why are we even doing monitoring to begin with? We want a lower rate of postoperative deficits. We want the exact same thing that you guys want, right? It doesn't, I can tell you that every time that your IOM person has said, hey, we have changes, and the response is, I didn't do anything. Well, it doesn't mean that there wasn't something systemic that impacted the physiology. It doesn't mean that, it's not an accusation, right? Typically the person's behind the monitor and they're dreading, having to deliver that communication, because we're rooting for the patients just the same as everybody else. We want a high level of consistency in our case outcomes. We want to be able to predict how the patient's going to wake up based on the data set. And for the most part, we're at a place where we can do that, aside from some of the things that we talked about earlier, which remain elusive. Hopefully in the future, technology will get us to a place where those mysteries become unraveled. And we want to give our surgeons the ability to safely navigate their most difficult and complex cases. And that's my chat on IOM for this morning. So I'd like a little bit of time for questions, comments.
Awesome. Thanks for being here. Yeah. Thanks for expertise and commentary, and really high picture, but also meaningful phenomena. So you pointed out the medical legal ramifications of neuromonitoring if it's not done. What is your thought in terms of, what is your recommendation to start there for spine surgeons when to absolutely do it? So what are the cases where you'd go like, as an experienced neurophysiologist, go like, that case should have probably had monitoring?
Well, so I've spent some time as an expert witness on legal cases, which gave me a really good insight into that lens of how to view things. What I would say is, right out of the gate, if the patient has symptomology, should be in the conversation at a minimum. At the end of the day, it's going to be, the surgeon's the captain of the ship, and you guys would be the ones who would need to explain that. But at a baseline, if there is symptomology present for this patient going into the operative theater, neuromonitoring should at least be a part of the conversation. Now, as to when to utilize it, I think the much more important question from a medical legal standpoint is how it's utilized. Right, so I haven't seen very many cases that hinge on did they use it or did they not use it, and I've seen a large volume of cases hinge on how was it used. Right, so if you say, okay, this is a spine case, let's bring neuromonitoring in because they have a high likelihood of problems, we don't want to deal with a lawsuit later. And the example I gave earlier, you run motors at baseline, you do your entire surgery, you run motors at the end, patient wakes up and they're paraplegic, probably going to lose that lawsuit.
So yeah, for our societies, deformities are a strong recommendation towards utilizing them, multimodal, and high-grade cord compressions with, again, a chance to modify something. I want to pivot to Dr. O. So those two beautiful tumor cases that our future partner, Dr. Kramer, featured. Is there a correlation of cord compression as a percentage of spinal canal and risk in terms of neurodeterioration? How do you recommend using stimulative neuromonitoring like motors in terms of timing through a surgery?
I mean, I think, again, this is just me. I think for routine anterior cervical fusions, lumbar fusions, I think it's surgeon, makes the call. I think for patients with neurodeficits, like the tumor, spinal cord tumors, I think it's invaluable. I do think, and this is just me, I do think that the information that comes in, most surgeons actually don't understand it. And unfortunately, the physician who's monitoring usually is not in the room. And so you get these changes and the tech is like, oh, there's a change, alarm, alarm. And the surgeon usually, kind of makes them freak out, stop doing what they're doing. So I do think, Amir worked on this with, I do think that understanding what those changes are and then modifying it, and then like your case, Jens, it's like you're doing a laminoplasty and you lose the motors, it just kind of really can shake you up. So I think for me, I tend to use it for tumors. And then if people have a deficit, like they're myelopathic, I think it's helpful. If they have true weakness, then it's again, it depends on the location of the pathology. We're very lucky at Swedish, and I pushed for this when I first came here. We did everything remote. It was, not in-house. And I fought with the institution to get a neuromonitoring program in-house. I think that makes a big difference. So I talk to Mike all the time. Yehuda was here before. Yep. And Nick, we're lucky to have you as well. It's one of these things where it makes a huge difference when, it's in-house. Mike's come running down to the OR, he calls. So having that local presence does make a big difference. And so again, I do think experience also is a big factor. If you're not doing spinal cord tumors, you're doing 1 or 2 a year, maybe you shouldn't be doing them. If you're, not doing lateral surgery and you don't understand, what are complications from doing lateral surgery, maybe you shouldn't be doing them. So.
Yeah, I think those are all wonderful points, and I would say that I'm very happy to be here, and I'm very happy to advocate for our in-house team and make, if there's opportunities for improvement with our in-house team, I want to pursue those, right? Like I want to have dialogue with everybody in this room, and I want us to collectively have access to the greatest tool set that we can. I think that one of the points that you made is a very good point, and we talk about morale in the OR, right? So if you say, okay, I'm bringing neuromonitoring in, but you don't have a plan on what to do if there's neuromonitoring changes, they're probably not going to be very helpful to you. They're not going to give a lot of utility. And you know what, honestly, sometimes the plan of what neuromonitoring can provide to you is an exit strategy, right? I know that everybody in this room who operates on patients, you have the utmost desire that we want to do this through to completion. We want the patient to be either better or stabilized on the backside of this, but we also have the do no harm element in play as well. And we see very, very complex cases here. And sometimes neuromonitoring can act as that alert criteria of saying, hey, maybe this didn't create an actionable interventional window, but this is the bellwether moment of this case really can't proceed. The patient is just not able to tolerate it.
Just wanted to add to that. So we still have it, but it's no longer of the same impetus at all. We have this Washington State Spine Registry and Spine Scope, and one of the things that we did was in very large numbers, imagine 5-digit numbers on either side, we compared spine cases, all comers, with and without neuromonitoring. The bias being the non-monitored cases were the less risky ones. Interestingly, the patients who had the neuromonitoring had far less deficits than the patients without it. We did not publish this, so this is not a fair statement, but the numbers were profound because there were methodological and data dictionary questions. But Dr. Shah and I had bantered around a manuscript for quite a while, and again, we then felt that we could not withstand the scrutiny of the methodology peer review sufficiently to actually put that. But for me, the data itself spoke so clearly that it was actually pretty profound to see the difference of use monitoring. And our inference was surgeons who have monitoring are going to be more careful. That was our thought.
Yeah, that's a great comment, and those challenges are very real in putting together large-scale data sets. And I think that, in the industry, we have an understanding that there is significant bias to that, right? So if you're doing a cervical case and it's a one-level case and it's simply to generate stability in the patient, has extremely mild symptomology, that case is less likely to be monitored, but that case is also less likely to generate deficits just at a baseline, right? And so it can kind of skew that data set. And I think that there's been papers that have been published where they look exclusively at monitoring versus unmonitoring in the entire pantheon of spine, and it's really just not fair. Any study that's past peer review that looks at high volume case counts demonstrably shows that neuromonitoring creates a safer environment. It creates a higher degree of predictability in what the outcomes are going to be, and it creates a much lower statistical rate of postoperative deficits.
Well, this will conclude. We're at time. Thank you so much, Nick.
Thank you, guys.